in conversation. Our guest today is Dr. Krishna Reddy. He is a cardiologist and co-founder of the CARE group of hospitals. He was the principal investigator of the Kalam Raju stent, which was a very affordable cardiac stent for poor patients, particularly who could not afford imported cardiac stents. He later founded a company that was focused on manufacturing and developing stents as well as catheters, which were low cost but also high quality at the same time. In 2018, he joined Access Health International, which is a global non-profit think tank on health systems, and since then he has been leading its work on strengthening health systems. Welcome, Dr. Reddy, to DD India.
Hi.
Let's begin with the Kalam Raju stent itself, which was introduced in the early 1990s. It was the brainchild of Dr. APJ Abdul Kalam, India's former president. How did you get associated with it? What was the thought behind it? And did it achieve the desired impact?
Yeah, we were at Nizam's Institute of Medical Sciences in Hyderabad when Dr. Kalam actually visited to see one of his colleagues admitted there. And typical of Kalam, I mean, he just, during the casual discussion, he said, why are we still dependent on imported drugs and imported devices? That is a very simple statement, but it resonates with the self-reliance in some of the basic technologies. So that small talk led to formation of a Society for Biomedical Technology with participation from the Council for Scientific Industrial Research and the Defense Research Development Organization, for which Dr. Kalam was the head at that point of time, and the Nizam's Institute of Medical Sciences team. So we started this project with that stimulating comment that we have to be self-reliant. And I think it resonates with the current slogan, that Atmanirbhar. But when we started, the challenge was very significant. There was no ecosystem for development of the medical devices. There was no regulation. There was no animal lab facility. There was not even a medical grade stainless steel, which was available in the country. So it was a challenging experience, but when we completed the development of the stent and successfully demonstrated that it is safe and effective in the first-in-man study across 10 hospitals in the country, we had that Lagan moment. I mean, we had absolutely inexperienced people, but were able to come up and compete with one of the best and the most challenging technology in medical devices. So that's how I think the beginning happened. And since then, I think we have been able to become self-sufficient with end-to-end technology from raw material to the finished product. And not only it is being used across the original stent, of course, we have evolved next 4th generation of stents in competition with the emerging evolution of the stent technology. And currently it compares with anything that is available in terms of its safety and effectiveness. It is being used more than 200 cath labs in the country. Not only that, we have been exporting some of these stents to the Europe and other Asian countries. That's, I think, for me, it's one of the proud achievement that what we dreamt almost 2 decades back is a reality today.
So did you derive a sense of satisfaction from this project, though you've come a long way since then? Because defense technology was not being used for war, but for a change it was being used for the benefit of humanity.
Yeah, it was the most satisfying achievement, I would say, that we can become self-sufficient in medical device technology, especially one of the most advanced medical device technology. And that triggered, in fact, a lot of other efforts among the medical device fraternity within the country. And now we are able to produce joints in the country, the valves in the country, and the stents in the country. So I think that gives a great satisfaction.
You told us about the various variations and upgradations of the stents that are now in the market. So are all of them now available on hospital shelves? Are they still being manufactured in India in good quantities?
Yeah, since the original stent, I think we have migrated to 4 generations of advancement in the stent technology. The latest is the drug-eluting stent with the bioabsorbable polymer. And most of these stents are available in most of the cath labs across the country. across all the 4 regions of the country.
In India, around 2/3 of the healthcare needs are met by the private sector, and most of the healthcare products like vaccines, drugs, testing kits, etc., are also supplied by the private sector. During the COVID crisis, we've seen an interplay of the public sector and private sector, like it is the case with most diseases and pandemics. How do you assess or evaluate the response of the public and private health sectors to this pandemic in India?
Yeah, so the beginning response, which is dominantly the public health response in terms of surveillance, the border controls, the case detection, their isolation, tracking, that was, I think, the most effective in the beginning of the pandemic. And subsequent lockdown has definitely reduced the reproduction rate from 2.8 to 1.3. But before it touched 1 and below 1, where actually the virus gets contained, we had the unfortunate migration of the people and the social issues of maintaining the social distancing, wherein we had no option but to actually relax in terms of the lockdown. But given this, as the pandemic will continue to grow, because we haven't brought it down below 1, there is a need now for entire system, both the private as well as the public, to jointly respond to this continuing growth of the epidemic until we reach a level of immunity. In terms of the private response, in terms of the material resources, for example, we were almost not having any capacity for personal protective equipment. But recently, we came to know that we are second largest producer of PPEs in the world. I mean, so from a stage of nothing to a stage where there is a surplus to actually export, that gives our resilience of the private sector to respond to a public crisis. But a similar collaboration and cooperation in terms of the private healthcare delivery system, that is the hospital delivery system, in my view, I think that did not happen because there was a focus on strengthening the public systems, the government hospitals, creating the capacity within the government hospitals, increasing the bed capacity, intensive care beds, the ventilator capacity. But however, given the public perception and the prevailing trust and prevailing behavior of the public in seeking healthcare from private sector, so there has been a reluctance of public to actually seek some of the public facilities, which I would say there are of quality facilities, but because there is a prevailing perception, the public are not seeking as much as they should the public healthcare facilities. So what's happening is you have surplus capacity in the public hospitals. In fact, the bed occupancy may be only 50%, some of the public hospitals which are converted into COVID hospitals. Whereas people are saying that the private hospitals are overfull. I mean, there is no bed capacity in the private sector. So if the planning happened right from the beginning, the moment we started realizing that we may not be able to continue the lockdown to a stage of containment, we require a joint response, a combined response to the private and the public. There should have been a planning, joint planning right from the day one of involving the private sector, identifying which is COVID ready, pooling the resources between the public as well as the private, messaging the public in a very clear terms of where they have to go when they need some test, when they need some non-COVID health need, or when they need a COVID need. So there is some gap. I would say there is some gap, but a lot of effort has happened, a lot of capacity has been created, and even now we can respond.
India supplies the bulk of vaccines and drugs for viral infections like hepatitis C and HIV. Do you see India becoming part of COVID-19 solutions as well?
Yeah, I mean, even though it is a sad epidemic, I think there is a silver lining for India in terms of both rising to the occasion of meeting global health needs, not only the country health needs, the global health needs of the vaccines as well as the drugs. We may not be in the cutting edge research, but still, I think one of the great development that happened is most of the public R&D units, including the Council for Scientific Industrial Research and the Defense Research, they have been opened up for the public-private partnership to jointly work on the development of the vaccines and the drugs. And most of our capacity has been already partnering with some of the global university, including the Oxford University, wherein we will be in a position to manufacture to meet the needs of the public. So we have already ramped up the capacity even before we had evidence that this vaccine is going to work. So I think we are sitting pretty in terms of able to manufacture as and when a proven vaccine is ready for manufacturing. Definitely we will be in a position to meet our own requirements, but also I think we may be able to meet some of the underserved areas like Africa and South Asia and other Asian countries as well.
How do you see the way India's testing strategy for COVID-19 has evolved over the past 4 or 5 months?
So India's response has been as per the scientific epidemiological response as per the testing is concerned. So it started scaling it up as per the requirement of the epidemic. So one of the indicators whether the testing is adequate or not is what is the positivity rate. That means if you're doing 100 tests, how many cases are positive? So if the positive rate does not exceed 5% as per the WHO stipulation given out in May, that means your testing is adequate. Only recently, I think in the month of June onwards, slowly the positivity rate has been climbing up, and more so in some of the hot metro cities like the Delhi and Chennai, Mumbai and Hyderabad, where the positivity rate has climbed to 20%. That means the testing today is not adequate. So it has to be much more ramped up as the number of cases are doubling every 18 days, 20 days. So that is a marker that your positivity rate is a marker whether your testing is adequate or not. So I think it has to be further increased. I was aware that the present capacity is about 5 lakh tests per day. But based on the doubling rate and the daily increase in the new cases, we may have to calibrate the number of tests that have to be done so that our positivity rate does not exceed 5%.
NIV Pune itself has come out with 3 types of testing kits. There's RT-PCR, there's IgG ELISA, and there is virus neutralization assay. What are the factors that need to be kept in mind in interpretation of test results?
Yeah, so broadly, there are 2 methods of testing. One is, are you testing for the virus, presence of virus, or are you testing for the immune response, that is the antibody response of the patient? So there are 2 types of viral testing. One is you amplify the RNA using the PCR methodology. Even a single strand of RNA can be amplified by this PCR methodology. Whereas the antigen-based testing, where you develop antibodies and you detect the antigen in the nasal swab or the oral swab. So there is no amplification. Whereas the PCR test is highly sensitive. Sometimes it can give false positive because of the contamination or testing methodology. Whereas the antigen testing, which is less sensitive, that means you may miss some cases, but it is specific. So if antigen test is positive, you don't have to repeat RT-PCR. If antigen testing is negative, you have to repeat RT-PCR. Antigen testing is much more simpler, much more safer. You don't require BSL 3 types of labs. You don't require significant protection equipment. And it is much more rapid to test. So these are some of the differences as far as detecting the virus is concerned. Detecting the immune response, which is equally important, especially for surveillance and calibrating the response, that has a different meaning and different interpretation. It only tells, suppose if IgG or IgM is positive, that tells you that the patient has been exposed to the virus. If IgM is positive, that means patient is exposed only recently, that is within 1 week, and possibly the patient may be infective, so you may have to do PCR to confirm whether the patient continues to be infected. But if IgG is positive, but IgM is negative, that means the patient must have been infected about about 2 weeks back, where there may not be active infection. So IgG only positive, but IgM negative tells you that the patient has been infected, may not be active now. But how long this IgG response lasts, I think still the experiments are going on. As of now, there is a 60-day evidence that the IgG persists up to 60 days. And some of the animal trials, they have demonstrated their persistence up to 90 days and beyond. So that is another crucial factor, especially with reference to the vaccine development. how long is the immune response is going to stay. So the serology response is more of an epidemiological tool rather than a clinical management tool, whereas the viral detection for diagnosing COVID is a diagnostic tool. But however, if you're not able to meet the PCR capacity, you may use the bedside or the rapid serological testing. Suppose if it is positive, that means at least you know that the patient is infected. Whether it's active or not, we don't know, but at least we know it is infected. If it is negative, that means at least patient is not exposed within 1 week to 2 weeks and is not, but it cannot be taken as a passport to join bike duties or passport that is secure from future infections. So I would say that the PCR is used in the clinical medicine, whereas serological test is used by the public health department to conduct the longitudinal course of the epidemic.
WHO says that the world is witnessing the second peak of the first wave, and this is not the second wave. So should this put to rest all speculation on a second wave of COVID-19 infections, and how should we prepare for the second peak of the first wave?
Yeah, it is only the same wave. I think it just second peak is because of distribution of the epidemic to the south of the globe. That is Asia, Africa, and Latin America. These are the countries which actually resorted to very rigorous lockdowns in the early part of the epidemic. So that explains why there is a delayed peaking of the epidemic in the southern region of the world. So it is not a second peak, but it is only the second peak of the first wave of the epidemic. And that is what we are witnessing across the globe. So as long as people are vulnerable, that means in the recently, like ICMR has published the seroconversion rate as done in April, where the seroconversion rate was about 0.8% of the population. That means still 99% of the population are vulnerable for infection. So unless the seroconversion rate reaches that herd immunity level, which is given by a formula actually, if your reproduction rate is 1.3 with social distancing and other measures, your herd immunity rate should be around 30% seroconversion. But if your reproduction rate is about 2.8, that means one person infects 2.8 people, your herd immunity rate will be around 64% of the people has to be infected. One good thing is that from the seroconversion study is coming out that compared to the positive cases, there may be 10 times more people who may be asymptomatic. That means who never developed symptoms but still got infected and got developed immunity. So that's where I think our response until the vaccine comes out will be to continue with rigorous social distancing, personal protection, and those measures, isolation measures and testing measures. We should not relax. We should not relax unless we are inching towards that herd immunity, or we have an effective drug, or we have an effective vaccine.
Well, the whole world is concentrating on COVID-19. How important it is to ensure that non-COVID-19 related essential healthcare needs of people are not ignored in these times?
Yeah, non-COVID needs are as important as COVID needs, especially those things which we cannot avoid. For example, vaccination, I think we cannot skip them. Antenatal care, we cannot skip them. The care of tuberculosis, care of HIV, we cannot avoid them. In fact, we may worsen whatever achievements in the tuberculosis control. And similarly, the dialysis patient, you cannot skip the dialysis. Chemotherapy, you cannot delay the chemotherapy. And medical emergencies, especially those warnings for the heart attack and warnings for the stroke, you cannot avoid. So to meet these non-COVID health needs, I think there has to be meticulous planning in terms of which resources you allocate to non-COVID health needs, whether these health needs can be met at home instead of people coming to the hospitals, except for the emergencies. In today's world, I think the consultations, your drugs, the diagnostics can be delivered at home, either through online services, just like the groceries and essential services are getting delivered at home. And more importantly, the mobile clinics. I think mobile clinics are one of the best methods to go to the home so that people don't come out of their homes to meet the diagnostic facilities or the hospitals. Yes, I do agree. I think this is one area across the globe, not only in India. I think they are facing challenges as to how to meet the needs of it. But fortunately in India, I think we have been used to using the telemedicine, the WhatsApp for accessing our physicians, our specialists. We give our mobile numbers to these people even before there was a regulation of telemedicine. So because it was already prevalent, I do know as a clinician that my patients actually reach out to me 24/7. They don't have to come to the hospital for most of the things.
So has COVID-19 given a push to telemedicine? Also, we've seen a number of instances of hospitals turning away COVID-19 patients, non-COVID-19 patients, pregnant mothers who wanted to get admission in hospitals for delivery purposes. What should these hospitals do in these circumstances? They say they simply don't have beds.
Yeah, in terms of the response of both private hospitals and the public hospitals, there is a glaring evidence that is coming out, that is the lack of the quality culture in the hospitals. Similarly, the lack of infection prevention and control systems, training of the frontline health workers in these things. So what it is resulting is that the hospitals which are not well prepared to handle COVID suspect cases or COVID positive cases, they are getting afraid to actually admit some of these COVID positive cases. The reason being that some of the frontline health workers, like the nursing staff who are continuously exposed to them, despite providing them the personal protecting equipment, some of these, because they are not well trained, how to don the PPE, how to doff the PPE, how to remove it, how to dispose it. So in the process, a lot of frontline health workers may be getting infected, and that is becoming evident. What is scary is that some of these frontline health workers are suddenly resigning and leaving some of these hospitals because of the pressure from the families. So this is where I think the hospitals have to rapidly train the staff. They're improving. They are rapidly training the staff, and they're trying to triage the patients within the limited resources, giving whatever protection people can be given in segregating COVID and non-COVID patients. The best would have been if the government contracts out a private hospital which is designed for intensive care of the patients. That might eliminate some of the confusion that's happening between the private sector as well as the public sector. It is a real challenge. At least if there is a communication or an online platform where all the hospitals can upload their bed position, whether they take COVID patient or not, whether they will admit a COVID suspect or not. I think if this basic information, a minimum set of information, can be quickly constituted as an app and be linked to even your Arogya Setu app, where people can be guided as to where to go when they need. And also providing helplines, online helplines. They are available, but are they really working? Whether the public is clearly aware whom to contact. I think a lot of communication is also missing in terms of the public communication and a coherent and clear communication, consistent communication. So that is the need of the hour, actually. And thirdly, in terms of the fear, especially in the context of social media, there is a much more need to communicate consistently. It need not be feared as much as people are fearing. I mean, they have to take precautions. At the same time, if you look at the infection fatality rate, it may be just 0.3%. That is 3 out of 1,000. I mean, as much risk as walking on our metro roads or driving on the metro roads. But we need to be clear what is the level of risk, what is the infection fatality, what is the case fatality, what is the risk in young people, what is the risk in old people. That messaging and assuring that at least people should not fear that their life is at risk, but at the same time, those who are vulnerable should be made it very clear that they need to be protected well from contracting infection. We may create new hospitals, we may create beds, we may create ventilators, but where are the people? Where are the nurses trained in intensive care or trained in ventilator management? We don't have enough critical care people to manage the ventilators. So the real shortfall is going to be the human resources, not the beds, not the ventilators. I think we need to be conscious about that and protect these people, give assurance to these people then we can handle it. I think it can be still handled despite relaxing from the lockdown.
Towards the end, what's been your driving force as you work towards reforming health systems and towards last mile delivery of health services?
So I think, the COVID, that is another silver lining that it has come to the top of any policy agenda of every nation. It has laid bare the huge gaps in the health systems, even the best of the health systems. What are the gaps that are there? So every country has to reinvest into public health. That means the disease control, the disease prevention, the social determinants of health. We don't have enough qualified public health professionals which are required up to the district level or even CHC level. So there is an urgent need to have qualified public health professionals. Our primary health care is not robust enough. I think there is a need to strengthen the primary health care. There is informal providers, there are formal providers, there is Ayush providers, there is allopathy providers. So there has to be much better organization of the primary health care where people know how to navigate the complex primary health care. So that is the second thing that we look at. The third is people have to be protected financially. I mean, there has been efforts at the state level and recently the PMJ and Ayushman Bharat, but that may not be sufficient, especially for the missing middle. The informal labor sector are neither protected by the social health insurance nor by the health insurance meant for the poor people. So that means the financial protection has to be expanded, especially during the times of the pandemic. I mean, some of the public health insurance programs, they haven't announced that COVID illness is eligible for coverage. PMJ has announced, but some of the state programs haven't announced. So the current coverage, despite covering half of the population, but when you look at out-of-pocket expenses, still 2/3 people spend out-of-pockets. So it is not sufficient. I think there is an immediate requirement to cover not only the number of people that are covered, but what percentage of their health needs are covered. That means not only the hospital care, but their primary health care needs. And third, what portion of their health expenses are covered? Because despite 60% coverage by PMJ and other insurance and ESI and other things, still the health expenses, only 1/3 of the health expenses are covered. 2/3 are still not covered. So that is another thing. The fourth reform is in terms of the strengthening of the public healthcare system. So there is still, I think, enough infrastructure created in the public healthcare. What it requires is autonomy and a different mode of financing of these public healthcare systems. I mean, today we finance them through a supply-based. It's not a demand-based or performance-based financing of these public healthcare systems. So there is what is called as demand-side financing of this public healthcare system so that they are made accountable and there is a motivation to do better. So when you strengthen the public healthcare system, you're creating a competition to the private healthcare system. So that's important. Otherwise, if there is no competition, then you will get a less value of services because the costs are increasing in the private healthcare system.
Essentially, you're driven by the need to fill the gaps in the healthcare system. Thank you, Dr. Reddy, for speaking to us on DD India.